afternoon and welcome to the Washington Medical Commission webinar series. Today we're discussing practicing as a physician assistant in Washington. Today we are honored to have a panel of subject matter experts, including Commissioners Mr. Jim Anderson, Ms. Teresa Schroeder, Dr. Diana Curry, and WMC staff attorney Rochelle Little. Before I turn the webinar over, I'd like to take care of a few housekeeping items. We encourage you to ask questions throughout the presentation, so look for that question box on your webinar portal, and we'll do our best to address all of your questions toward the end of the presentation. We hope that you do not have any technical difficulties, but if you do, look for the help button on the same webinar portal to get your issue worked out. We are recording this webinar, and the on-demand version and slide deck will be available on our website within the next few days. Please feel free to share these resources with your colleagues. We want our learning events to be as interactive as possible, so please feel free to use our social media platforms to share what you've learned and keep the conversation going. Now, with all of that out of the way, I'll turn it over to Ms. Little.
Thanks, Jimmy. So I'm just going to see. There we go. The agenda for today's presentation is going to start with an overview of the PA laws and regulations from me, and then we're going to cover some common issues and concerns from the Commission. And Mr. Anderson is going to talk about PA clinic ownership, and then Ms. Schimmels and Dr. Curry are going to cover MD-PA supervision, and we might all sort of jump in at any point to help each other out and try to respond to your questions. So with that, the first section is about laws and regulations. And I thought I would start with just a few definitions of some of the terms that will come up through this section. You might know already that laws are also known as RCWs, and those are passed by the state legislature. So the Commission doesn't get really a choice in what the laws are. They're also known as statutes. Statutes and laws mean exactly the same thing. Rules or regulations, as they're also known, are codified in the WAC, Washington Administrative Code. And those are created by the Commission with opportunity for public comment. And they're usually introduced when a law states that the Commission needs to create rules to implement the statute, or the Commission might make rules to set standards for practice. And rules do have teeth. Like laws, they can be enforced by the Commission and the courts. We'll also talk briefly about interpretive statements. Those are a written expression of what the agency, or in this case, the Commission's opinion is as to the meaning of a statute or a rule or an agency order. We also have policy statement, which is a description of the agency or the Commission's current approach to implementing a law. And then there are guidelines, which are recommended practices that the Commission drafts to assist practitioners about appropriate healthcare circumstances. And then the guideline is just exactly how it sounds, a guideline. It does not have the force of law, but the Commission or courts could cite to a guideline as persuasive authority as to what the standard of care is. And then the last word here, procedure, that term is talking about how the Commission goes about its business. And you can find all of examples of all of these on our website, and we'll go over a few today as well. So one of the, let's see, and make sure that this is the next slide here. Yep. One of the important things in the law, and this didn't change with the changes in the law that are coming up, but in the RCW, physicians and PAs share liability and responsibility for the PA's conduct during care. And so what that means for you is that you need to make sure that you set up meaningful supervision specific to your practice. And what meaningful supervision means to you is not defined. It's not set out exactly what that needs to look like. But we're just suggesting that you think about what that would mean in your practice, what kind of supervision is necessary, and we'll talk more about supervision later on, that will ensure the quality and safety of the care for your patients. When there's an issue regarding a PA's performance, there's also, under the Uniform Disciplinary Act, a provision for disciplining physicians that failed to supervise a PA, and that's under the paragraph 14 in the Uniform Disciplinary Act, cited it there. So oops, that was accidental. When we receive a report or a complaint regarding a PA, the commission does look at whether to authorize an investigation against the supervising physician at any point at the beginning, or if more information is learned, but that's always considered. And then even if the investigation does not include an investigation regarding the supervising physician, the investigator would contact the supervising physician almost in all cases, just to find out, what the supervising physician knows about the situation, and what the supervision was for that patient. So another really important thing, there's some changes coming here to practice agreements, which are currently called delegation agreements, but starting in July, the new law is calling them practice agreements. And right now, there's delegation agreements that are codified in the WAC, but that's moving to the RCW. And there's going to be also a change to the filing requirement. It needs to be filed with the commission still, but the commission's not going to review and approve these any longer, like we currently do. So that's going to be a little different, but you still have to have one on file. There's some new provisions that are being added to the requirements, what needs to be in a practice agreement, a communication provision detailing how you would communicate between each other, and then a termination provision, which allows the agreement to be terminated. And there's a 30-day notice, written notice required, but if there's a good faith concern regarding unprofessional conduct, that can be terminated immediately. There's also changes coming to how many PAs one supervising physician can supervise. What's not changing is that it needs to be no more than the physician is able to adequately supervise. That's staying in the law. And then right now we have a current maximum of 5 PAs per supervising physician, but starting July 1st, the new limit is 10, and that can actually be increased beyond 10 with a waiver that can be sought from the commission in appropriate circumstances. And you'll just have to, if that's your case, your situation, you would need to explain, how the physician is able to adequately supervise more than 10. There's also currently a maximum on 3 of the PAs working at remote sites under 1 supervising physician. And the new statute just doesn't discuss at all remote sites. So that means that if it's appropriate and supervision can be done adequately, any number of the PAs that a supervising physician has could be working in remote sites. So this slide is just kind of really emphasize how important practice agreements are, and that it's really essential to always have a practice agreement on file, that it's not legal to ever practice without having that practice agreement on file, and then that both the PA and the supervising physician really need to pay attention to what you're putting in that practice agreement and make sure that you're also following it during your practice, maybe revisit it from time to time and update it to make sure that it's current and accurate with your practice. Okay, so another thing that's in the law is the scope of practice. And what's important about this is that the PA's scope cannot exceed the supervising physician's scope. So that's going to fall under the limits of the physician's knowledge and skill. And there are a few narrow exceptions that you might find in a rule of law or interpretive statement, something like that. But for the most part, those even if the PA does know areas that the supervising physician doesn't know, so let's have a discussion about that. So what can you do if you're an experienced PA, but your supervising physician is not knowledgeable about an area that you would like to practice or a treatment that you would like to offer your patients? So is there any, and Jimmy, I might need your help with this part. If is there a way for participants to kind of chime in on that discussion, or we can?
Yeah, folks can use the chat and questions. You can raise your hand. I can unmute you. But we don't have anything right now. Oh, hold on. I have someone. Bonnie, I'm going to unmute you.
Am I unmuted now?
You're unmuted.
Great.
I can hear you,
My
Bonnie.
question is about prescribing buprenorphine or any other kind of treatments for addiction in the primary care level. If you, like currently, I know the legislation is changing, but like I'm a waivered provider. And I've worked in places where my supervising physicians like have not been. So I'd like to kind of understand the role there.
Yeah, and maybe I'll let Jim jump in here for that one.
Hey, Bonnie, great question. This is Jimmy Anderson, PA on the commission. And, you know, you're right. There has been a change recently. To get the X waiver, as you know, I got the X waiver a while ago too. And to get the X waiver, which allows PAs and NPs, or in our particular concern, PAs to prescribe Suboxone, you used to have to take a 24-hour online training, or it could be online or a combination of online or in-person training. And then once you did that, then you would be able to get your X waiver, which would allow us PAs to prescribe Suboxone for the treatment of opioid use disorder. And then just recently, the Substance Abuse and Mental Health Services Administration, SAMHSA, who oversees much of this process, along with DEA, noted that there's been a legislative change, and I think this came as an executive order, perhaps from the current White House administration. But basically, to get an X waiver now, I'm not sure if it's enforced, but it'll be enforced soon. The PA only has to do what, basically apply for it. You know, it's called a notice of intent, a NOI, and then there no longer is any specific training or certification required. Then the PA has the ability to initially see 30 patients, and they can see more a year or so down the road. So there's been some controversy about that. I think it's a great thing. I think I think it's really going to increase the access to care. There certainly are things to know before prescribing Suboxone, but for a PA to do that, you know, the standard of care as a PA would need to have the skills and knowledge available to do that. But so that is a change that's happening right now. The question, Bonnie, you had about what about if your supervising physician does not have a waiver and you do, can you or any other PA in that situation prescribe Suboxone for the treatment of opioid use disorder? And there also has been some, I guess, lack of agreement between various state medical boards about this. The Washington Commission has taken the stand and has has noted it in documentation is, I mean, it's part of our policy that it's our interpretation of the law that created the X waiver that a PA who has an X waiver can use it even if their supervising physician does not have an X waiver, but there's a caveat, and the caveat is that the supervising physician needs to be eligible to get an X waiver. And right now, of course, that's, I mean, it's pretty simple to get an X waiver. So that's the current stance of the commission, is that, and this stance was done when you have people, you know, PA, I mean, MDs had to do 8 hours, PAs 24 hours of training to get the X waiver. Now with the change at the legislative and administrative level in DC, Washington DC, people still have to apply for it, but you don't have to do any training to get it. So my understanding is that the commission stance will continue to be the same, which is PA can use their X waiver if their MD is eligible to get an X waiver. And right now that means pretty much any MD is eligible to get an X waiver. So that's my understanding. Does that address your question, Bonnie?
Yes, thank you very much.
Sure.
Yeah, and so that's that's one of those narrow exceptions, and we do have a slide about that later as well. But I'm not familiar with the federal changes that Jim's talking about, but we do have, I can't remember right now whether it's a policy or an interpretive statement, but we do have that, and it's in a later slide. And it does talk about training, not just eligibility, but there may be some training that's mentioned, but that's again it's not the force of law. It's not in a rule, but it's one of those exceptions. So going back to what can you do if, as an experienced PA, you would like to practice some treatments that your supervising physician is not knowledgeable about, that are not specified as an exception, such as Suboxone. What are some options that you could pursue? And I thought, Ms. Schimmel, did you want to chime in about that one?
Yeah, thanks. My name is Teresa Schroeder. I'm a physician assistant commissioner. I am in Spokane, Washington. So one of the things that you want to make sure is that you discuss with your physician as a team member what it is that you'd like to do. And again, just like with the Suboxone, you want to make sure it's something your doctor would be able to do or step in to help you if you needed that. And then you need to make sure you get the appropriate training and certification for that, and that you have it added to your practice plan or practice agreement, as we call them now.
Right, and then another good option that that is available is having more than one physician on your practice agreement. So you'd have a separate practice agreement with another physician that can supervise you in that area, or have alternate physicians listed on a single practice agreement where some of the physicians might have different scope of practice and knowledge that
yeah, or subspecialties. Yeah, we definitely see that in some of the surgical subspecialties, or especially say dermatology, where maybe one of your docs doesn't do any type of plastics or injectables or things like that, but one of your other docs does. So you would make sure you had both of those signatures on your practice agreement.
Yeah.
If I could also just add something, I would add that I mean, I think PAs in this particular area that we're describing do need to proceed with caution. For example, if a PA has experience, and especially in education, about prescribing ketamine as an outpatient oral setting, and if the supervising physician does not have any experience with that, I mean, really the way the current law is, then the PA shouldn't be doing that. There are, I think, some creative ways to approach that, which Teresa and Rochelle just brought up, and those are really important and it's important that PAs proceed with caution. And if you're not sure, you can always ask the commission, and we can give you some guidance about what our understanding of the of your situation is.
Thank you. Yeah. So just one quick thing about scope of practice. If for some reason your supervising physician has a discipline case and their scope of practice became limited, then the PA's scope would also become limited. And that's a rule that is in the WAC. So if you were to find that, hopefully you wouldn't find that yourself in that situation. But if it did happen, then it would be important to either change your scope of practice to match that physician's or find a different supervising physician. Another change that the law is bringing in July is that all PAs are going to be under the medical commission. There aren't going to be any PAs that are regulated by the Board of Osteopathic Medicine and Surgery. And so that's changing. There's sort of like a transition period, and on the renewal date, that if you're a PA that's supervised by a DO, your licensing will switch over on your next renewal after July 1st over to the medical commission. If for any reason there was an investigation opened regarding the supervising physician, that would still be handled by the osteo board. So now I just wanted to talk about a couple of policy statements very briefly, because we talked about what is a policy statement, and these are on the website. So for example, we have a policy regarding self-treatment or treatment of immediate family members, and that talks about potential pitfalls that you might come into if you were to decide to prescribe something to a family member. And then practitioners exhibiting disruptive behavior and how that falls under the commission's jurisdiction to investigate and take action on. And I just pulled these up as examples just because I think that they're, they come up from time to time and they apply to both physicians and PAs. So they're good policy statements to use as an example, and those are on the website. And also they'll be in the handout. A link to them will be. And then interpretive statements. We just talked about the one about the X waiver. And so this is where you can find the full interpretive statement on our website about that. And then there's also one about ordering restraint seclusion in that practice area. There was a question that would come up about whether that was something a PA could order, and the commission's position is yes, PAs can order it as long as the delegation agreement doesn't exclude that, and that the supervising physician also practices, is able to order that. Okay, well, I'm going to hand it over to Jim next to talk about clinic ownership.
You're on mute, Mr. Anderson.
Sorry. Thank you. And can we go to the next slide? Is there a next slide? There we go. So the bottom line, the commission has opined via a guideline that PAs can own a clinic. And it's allowable. It certainly comes with some specific challenges, and I think it's important to be aware of what those challenges are. Some of them include like scope of practice. I mean, if a PA owns a clinic, they still have to have a supervising physician, and they still have to have the appropriate agreement in place between the supervising physician and the PA. That doesn't change. And the scope rules are the same. They have to be practicing within the same, generally speaking, except when there are exceptions, they have to practice within the same scope. They both are still mandatory reporters and certainly that might include of each other. And it's important that they are really clear about staying in compliance with those rules. And also, there's a kind of a red herring, and I still don't exactly know how this will play out, but physician cannot be required to supervise a PA as a condition of employment. And we've discussed this, and I think, does anybody have a recollection of where our discussion has led as far as what exactly this means? For example, if a PA were to hire a physician to be their supervising physician, the PA would want them to be willing to do that. And I don't think this wording was meant to say that if a PA hires someone to be their supervising physician, the person could then say, I don't want to do that. But does anybody else have any other clarifying thoughts about this?
I do, Jim. This came from a discussion about, let's say a physician owns, or a PA owns a clinic and maybe has 2 or 3 physicians and 2 or 3 other physician assistants in the clinic. Making the physician be responsible as the supervising, to supervise the physician assistant is not a requirement. You can hire the physician to work in the clinic without them being a supervising or sponsoring physician. So that's where that came from. Just because the physician's working at the clinic doesn't need to necessarily mean that they're the supervising physician. I hope that kind of makes sense, but it's not a condition of employment. If the physician assistant wants to hire a doc, he can hire a doc, and that doc does not necessarily have to be the sponsoring or supervising phisian.
Right.
Clear as mud?
Not well, although the PA still has to have one, but maybe it's just not going to be. Maybe the PA is going to hire 3 doctors, right? And maybe only one of them is going to be the supervising physician. Yeah, I mean,
exactly.
I think that's the intent of it. I don't think it's really well worded, frankly, but I think that's a great way to understand what this wording means. Okay. So there we go. So here's a few kind of case studies. Let's say a PA owns a clinic and the supervising physician is employed by the PA. And the supervising physician provides substandard care. Here's a few examples. Inappropriate prescribing of hormones, poor documentation, using controlled substances for personal use, and when the physician exhibits behaviors, substance abuse, aggressive, threatening behaviors. So I think that we can go to the next slide. In this case, should the PA be disciplined if they do not report their supervising physician for those about those concerns? And so I believe you can, Mickey, how does this work? I mean, Jimmy?
So I've launched the poll and people are answering. We'll give them we're about halfway through, so I don't want to spend too much time on these poll questions, but we'll give a couple more seconds to log your answer and then we'll view the results.
Very good. So shall we move on? Here we go. Great, savvy group. Yes, indeed. The answer would be that the PA could be disciplined for not reporting their supervising physician. I want to add one other thing too. The Washington Medical Commission doesn't wander around looking for cases to discipline people about. So it's just important to understand that the commission is driven by complaints. And if there's a complaint that we get about something, and when looking at it, we find something else, then we'll follow up on that. But there is not there are not a group of investigators roaming the state, knocking on doors to make sure everyone's following rules. And I think it's important to note that. The next one, case study 2, PA owns a clinic. Supervising MD is the PA's employee. Let's say the PA is not following a delegation agreement. PA is acting in sort of a maverick fashion. PA fails to carry out supervising physician's directives regarding patient care. PA performs surgery without physician supervision. PA is practicing beyond the scope of supervising physician skill and knowledge. So in this case, it's the reverse of the last question. Should the supervising physician be disciplined for not reporting this PA to the Washington Medical Commission? Maybe take a few seconds and cast your vote. Exactly. So bottom line here is PA still has a duty to report behavior on the part of the physician that they are concerned as a violation of the Uniform Disciplinary Act of the state of Washington, and vice versa. And it certainly would be more complicated in this situation, and that's one of the ethical dilemmas. But both the PA and the physician are expected to work with the highest of professionalism and ethics, which would mean they would be expected to report. So let's see. Here's case 3. PA owns a clinic, employs physicians, MAs, etc. The supervising physician's employment ends, and the physician is no longer supervising the PA. PA continues to practice, but without a new agreement without a supervising physician in place. What steps could the PA have taken to avoid this violation? And what steps should a physician take when leaving employment?
So in the interest of time, I'm not going to unmute folks, but I would like for you guys to put your discussion questions in the question or chat box so that we can answer them. But if any of the panel wants to do a quick discussion on this, that would be great. But we're going to leave this discussion question to the end if we have time.
I think that's fine to do that.
And Jim, these are great studies. All 3 of these are actually actual cases that we've had within the commission over the 8 years I've been on the commission. The big thing is to make sure that to avoid the violation, you can't see patients until you have a supervising physician. So you need to get a new supervising physician, and you need to get a practice plan in place. Don't forget to discontinue or terminate the previous practice plan as well. That's very, very important. And the physician should also make sure that that practice plan is voided. It's partly or terminated. It's also their responsibility as part of that MDPA team. So these are great cases though, and these are things that do happen. And
Teresa?
I guess that's,
yeah,
I guess it's thanks right into me. So we'll talk a little bit about some practical advice as a physician assistant working with the PA team. And the big thing is a little respect goes a long way. Respecting your physician and the other providers that you're working with as a team are super important. You may do things differently. That's okay. You just need to make sure you have a respect for how that works. I work with a doctor who is not as extroverted as I am. And I am very much an extrovert for those people that know me. And we work really well together. She knows my strengths, I know her strengths, she knows my weaknesses, and I know her weaknesses as well. And we are a great team because if she doesn't know something, she comes and grabs me. If I don't know something, I grab her. And it works just really well. Respect what you can and cannot do. You need to know what you don't know. It's super important that we're lifelong learners. Do you have the technical training or the knowledge? And if you don't, then you need to seek that out. It's a little tougher to go to a conference, but it's a lot easier to get information right now with a lot of the telehealth or the teleconferences, the Zoom meetings and the GoTo meetings and that kind of stuff. Electronic conferences are just wonderful right now. Go ahead to the next slide. So supervision, there's a couple different kinds of supervision. Remember, we are not independent practitioners per se. We may act autonomously, and I am very much autonomous in my practice. Direct supervising or supervision involves the physician being physically present for a patient encounter. I often do that when I have a very complicated case that I don't feel comfortable with the patient and what I'm finding, and I'll grab my doc and we'll kind of go over everything together in the room. Indirect supervision means the physician is available by phone or electronic means, texting. Gosh, we now have that Microsoft Teams, all these other options, or just by phone to be able to review a case and ask a question if we have one. This was really important in previous remote site supervision, which we no longer have to have a remote site practice plan, but you still want to be connected. The supervising physician is responsible for ensuring that the PA is adequately supervised, which means reasonable access to the supervising physician should the PA wish to consult the physician. It's nice in a practice where you maybe have 2 or 3 doctors that are on your practice plan or practice agreement as well, because then you can defer to another one if there's a vacation or something like that. For me, I have one dermatologist I work with, and when she's gone, I go to the chief of services, and she becomes my supervising physician for the time that I'm gone. So it works very well. And again, this is all part of that team practice. Next slide. So this is really important, and I'm going to ask Dr. Diana Curry to help with this too, as far as supervision goes. Dr. Curry works, well, I'll let her introduce herself. Go ahead, Diana.
Hi, good afternoon. I'm Diana Curry. I'm an OBGYN MD, and I work with PAs, and I'm happy to be here and talk more about this with Teresa.
So supervision is a really big part of PA physician practice. So what's really important is that you have a clear and appropriate level of PA physician by the supervising physician. And you need to work that out. You need to speak up as a PA to talk with your doctor about that, to make sure that you have kind of the lines drawn, what your doctor expects from you, what you kind of expect from them as well. It's a two-way street that you need to work together. Ensure that there's a plan for open and consistent communication. So Dr. Curry, you want to talk about kind of how do you contact your PA if there's an issue?
So I think that it varies by the practice and whether you're physically co-located or in the office on the same day or at remote locations, but absolutely having synchronous, like real-time availability is, I think, the minimum standard. Sending a staff message through the electronic medical record with that asynchronous sort of support is okay in less fraught situations, but if you have a question that you need answered, a patient sitting there in the office right at that moment, I think that it is incumbent upon the physician to be available as much as possible. Obviously, there are times when you're in the operating room or whatever, you can't get there, or answer a phone call, but you've really got to try to make that the standard that you aim for.
Mm-hmm. Yeah, and I think we all have a cell phone, pretty much everybody does. So there's no reason not to be able to get your doc's name and number stuck in your contacts so that you can speed dial them or have a text message to them. Don't forget to document in the electronic health record when your supervising MD is present for an exam. It's super easy. I just write at the end of the note, Dr. McKee present for exam and history, or precepted and patient discussed thoroughly with recommendations made by Dr. Marion Mitke, who's my primary supervising physician. And then also CC the doc in their note, especially if you want them to have a chart review specifically over something. Maybe you're starting a new therapy, or you're doing something with a patient that used to see the MD. You know, it's very nice. It's a courtesy to do that. But it's also good just for the fact that you want to have that continuity of care going on in the office too. Okay, next slide. So Dr. Curry, do you want to talk about the value of teams? Or do you want me to discuss? I can read through this.
I think I have some slides after you, Teresa, so keep going. You're doing great.
Okay, great. So growing interest in the team-based care has led to this high-functioning teams and the positive impact on outcomes. But we also know that it's efficient, it's cost-effective, and it really helps with provider burnout. Working on a solo team is a lot harder than working on a regular team, and that's why PAs have been so beneficial to physicians all these years, because we work as a team. So To Err is Human unleashed a new interest in team-based care. The report identified effective team functioning as one of the 5 principles that could lead to safer care. There's lots of reports out there that have placed interdisciplinary, collaborative, and team-based care at the epicenter of healthcare transformation. And we are going to continue to move towards that with PA regulation. Go ahead, next slide. Improving care is also one of the bonuses of what we're doing with team care. A 2018 report from 3 federal departments recommends that to lower prices, increase access, and improve quality, states should allow healthcare providers to practice at the top of their license using their full skill set. And most PAs I know are very well utilized. I know in some areas, maybe in bigger regional medical center areas where there's maybe a large influx of PAs, a lot of them may not be working, but I can tell you the folks that are out in the rural clinics are working to the top of their game. Consider eliminating requirements for rigid collaborative practice and supervisory agreements, which is what we've done now here in Washington State, and really want to thank the PA group here in Washington for that. And then allow PAs and other providers to be paid directly for their services, not so much as so in as much as trying to get rid of the 85% rate and get paid at the full 100% rate, rather at a discounted rate as the PAs and nurse practitioners used to be able to get, or used to charge for. Next slide. So just to wrap all that up, it's super important to make sure that you have the team, that you have the communication, that you are working to your potential. And if you're not working to your potential, discuss it with your physician. Discuss it with the practice manager if you need to. There's a lot of ways that we can really contribute to make the team most efficient and cost effective. Dr. Curry.
Okay, Jimmy, go ahead and move on to the next slide. So I'm going to talk about things a little bit from the physician point of view. Not to belabor the point, but there's a lot of literature out there that supports the use of PAs, the safe collaborative care that can be delivered. It's supported just over and over again in the literature. Let's go on to the next slide though, for the sake of time. Okay, so thinking about supervising PAs, a lot of physicians are a little bit hesitant. They feel like they barely can keep up with their own patient panels. They're afraid to take on more. They're afraid to take on risk. So I think that is a maybe natural way to feel, but in reality and based on the literature, it's not supported in the sense that if you start out with really good communication, an understanding of what your PA can do and what you can do and how you collaborate, how you communicate, things generally go very smoothly. So there's two, I think of supervision as starting out with sort of the initial phase and then the ongoing. So initially, there has to be a building up of the relationship and the trust between the two providers. So if it's a brand new PA, which I've had the pleasure to work with myself, they are your little lump of clay that you get to mold into thinking about patient care, very similar to how you think about patient care. So it's an opportunity to educate. And I think all of us that have gone through residency understand how medical people get educated, right? We all educate as a second year resident, you educate your intern, et cetera. So we know how that education works. We do it naturally. We know how to do it. You don't have to learn anything new. It's easy. Just adopt the same techniques that you did when you were a resident or being taught by your attendings. Initially, I think that having some direct supervision is important, so you get a sense for how your PA speaks to patients, how they listen, for procedures, certainly, even if it's an experienced PA and you're a brand new supervising physician with them, you might want to watch them do a procedure once at least so you can see how they do it and make sure you're comfortable with that. Talk through any differences that they might have from how you do it. So that, again, building that trust, it's all about communication. And then over time, you're going to develop the relationship in such a way that the PA is doing more and more things independently. Just like in residency, you go through internship, second, third, fourth year, you begin to do more and more things independently. It's very much the same. That's mostly true with new PAs, but even with experienced PAs over maybe a shorter period of time, the supervising physician is going to get comfortable with them doing more and more procedures. To continue the communication, it's important to put into place regular meetings, whether it's weekly or monthly, whether it's by telephone or text or in the hallway, some way to just say, hey, how are you doing? Any weird cases, anything you're concerned about? That touch base is very crucial to that open door policy, and that's what it's all about. You really need to be there for your PA when they have a question. So although I've emphasized that teaching or working with a PA and kind of developing them in your practice, for example, is not dissimilar to how we did it in residency, one of the differences that I see is that when I'm teaching a resident, they're concerned when they present a case to me that they might have the answer wrong, right? Because I'm teaching them, I'm grading them, I'm promoting them to the next level. There's a little bit different relationship with the PA who you're not grading them, you're helping them mature and become a better clinician or become a clinician more knowledgeable in the practice that they're in with you at that moment. And so you have every possibility to just give them that knowledge, give them the answers, encourage them to ask questions. There's no judgment. There should be no criticism or kind of feeling that the PA, if they didn't get the answer right, is going to feel bad. That we don't want that to happen. That's a difference in how we teach medical students or residents than PAs, in my opinion. In terms of education, both my PA and I, when we go to conferences, we bring PowerPoints back, we bring handouts back, we bring pearls of wisdom we learned, and we share them with each other. So very much having that open sharing, resources available to both of you is key to, again, collaborative care and team-based care. Okay, let's go on to the next slide. So in terms of ongoing quality assurance, some sort of chart auditing is probably a good idea. I don't know that there's any literature to support whether it's 5 charts or 15 charts a month or a quarter or whatever it is, but it is recommended that within the practice agreement, the PA and the MD have some sort of understanding of some ongoing auditing that's happening, a mix of diagnoses, whether the frequency, again, is every week in the beginning, maybe with a new PA, and then once a month or once a quarter over time with a more experienced PA. But some clear communication and expectation around that. It's easy for time to go by, and if you don't have a cadence set, it's easy for 6 months to go by and you haven't really talked to your PA about anything. So we don't want that to happen. We want you to have it in the practice agreement and show that you are doing it. That's part of one of the things we look for when we are thinking about adequate supervision, if there is a complaint about either the PA or the MD. In terms of the protocols for complicated patients, I think that that's very much practice dependent and dependent on the unique individuals involved. But there are some best practices. So there are certain times when you would say, hey, for me, I'm OB. For every pregnant patient, you have to get a type and screen. I need to know her blood type. Like that's just a protocol or a, hard and fast rule you're going to follow. Or, for example, if it's a complicated patient and they've seen the PA twice and there's still not really a good plan of care or resolution or decision about the diagnosis or care or medications to use, et cetera, that really the third time the MD should see them. So I have seen some people put that sort of algorithm into their practice plan. So for a new patient with a new diagnosis, if there's not sort of decision resolution by the second appointment, have that third appointment be with the MD. And from both provider's point of view, it kind of, makes sense, right? It covers yourself. Like you have the opportunity to then check each other. And that's just best practices. Create that culture that always encourages questions. That's really what it's about. Go ahead to the next slide, Jimmy. Okay, so just to quickly go over complaints that we receive, it's about the same for PAs and MDs, 4.1 per 100 for PAs and 4.0 for MDs. So really not anything different. Next slide. This shows the complaint demographics, so to speak. What are the complaints about? Are they, mandatory malpractice reports? Are they substandard care or service, poor service reports? Are they, actions on a license in another state, fraud, infection control, et cetera? So this shows the MD graph, and the next slide shows the PA graph. And the main difference is there's maybe a little bit less of the medical malpractice reports in the PA world of complaints. And let's go on to the next slide. And so here's a quick case study. If you have a PA that provides substandard care, maybe it was a complex patient, there was a lot of polypharmacy, there was a lot of multiple comorbidities, and the PA doesn't consult with their supervising MD, and there's no evidence that the physician ever reviewed that particular chart or was consulted, and yet they do have a practice agreement on file, and that supervising MD was available to consult with, but the PA just never approached them. And then, maybe they don't really have any regularly scheduled meetings to review their cases, or they say they do in their practice plan, but they're not really doing it in reality. So in this situation, what do we think should happen? Go ahead to the next slide. So assuming the PA is disciplined for a violation of standard of care, should the supervising physician be disciplined for not adequately supervising the PA? Now remember, in this case, the PA didn't actually reach out to the MD, so the MD may not know anything about the case. So what do you guys think about that? We'll just give a couple seconds here and then move on. We want to have time for questions and answers too at the end. Are we there, Jimmy? Okay, so interesting split. And that's really good. So, roughly almost equal parts of our audience are saying, yes, the, supervising MD should be disciplined for not knowing what the PA was up to and not supervising well. Maybe no, and maybe it depends. So moving on to the next slide. I think that was exactly what we wanted everyone to think about, which is that it depends. It really is the case that in these kinds of situations, every unique situation, the Washington Medical Commission looks at it as an individual case. There is no rule of thumb. There's not a if this, then that. It's what happened, what are the particulars of the case. It's very much dependent on the individual situation. So we don't have a rule of thumb. What we would encourage people to do is if you're stuck, if your patient's not getting better, talk to the doctor. If you've seen them a couple of times and you feel like you're kind of flailing around, or if you're sensing, if your little emotional IQ is telling you, this patient doesn't seem happy with my care, this patient's getting frustrated, send them to the MD, right? We're the backup, use us. Like that's what we're there for. We won't always know unless you reach out to us, especially in a busy practice, especially with a really highly competent, experienced PA. I'm not going to go looking. It's kind of like medical commission doesn't go looking for cases. I don't go looking for problems with my PA. If I say to her, hey, is everything okay? Any patients you want to discuss? And she says, no, I'm fine. I believe her and move on, So just making sure that you keep that door open for communication. Okay, I think that might be the last slide. Any questions now? We'd all be happy to answer any questions from the audience in the last 5 minutes.
Yeah, and just a quick reminder, we do have a specific webinar coming up on June 16th. A link to that will be emailed to you after this presentation, but this is going to focus specifically on questions regarding the new law and the effects that will be taking place July 1st. So be sure to look for that link and register if you are interested. And then I hope everyone will join me in a virtual round of applause for our panel. Thank you so much for your wonderful presentation. Go ahead and ask those questions. We do have a couple minutes. We'll try and get through as many as possible. So while questions are coming in, we have one from earlier, and it's, if the physician doesn't do that particular procedure or medically treat that patient population, would the PA be able to do that procedure or treat that population? When you're talking about having the skills or training, what does that mean to the physician, the PA, or both?
I would just, I would say that that's sort of 2 or 3 questions, and they're all really good questions. But my understanding of the question is, if the PA has skills, knowledge, skills, or ability that the MD does not have, that the PA is not supported in doing those things, unless the MD has that knowledge and those skills and those abilities, in a nutshell.
Yeah, I would second that with what Jim said. You know, plus, I mean, you don't want to be in an adult internal medicine practice and see pediatrics if your doc isn't going to see pediatrics. You know, what are you going to do in the case of the emergency? Yes, you may be able to handle the emergency, but ultimately it's you and your doctor that are responsible for that patient. And the doc has to be able to have the ability to take care of a pediatric patient as well. So.
I agree. Scope of practice is scope of practice. So whatever your doc can do, you can do. But if the doctor does not do it, if it's something they simply don't do, you probably shouldn't be doing it. Or you can be doing it if there's another supervising physician that's agreed to supervise you, even if they're a remote supervising physician.
And then our next question is, can you confirm that the supervision of PAs in a remote site will no longer will require 10% face-to-face time?
Jimmy, I think that is correct with the new practice plan and rules. I don't think that there's that, you don't need that specific. Rochelle, do you know off the top of your head?
Yeah, the new law doesn't mention remote sites. Remote sites are not in the equation. So
Yeah,
it's
we're getting
just,
rid of them.
yeah, they're not defined, they're not restricted. It's up to the PA and the physician where each of them will physically be and how they will manage their communication.
Right.
One thing I'd add, though, is we know that people working by themselves in remote sites without direct kind of collegial support are slightly more at risk for problems occurring with patients and patient care. And so it's even more important to have that mode of communication worked out with your supervising physician. I know that one thing that a lot of people do is they take pictures. So a lot of electronic medical records will lend themselves to taking a photo. So my PA, when I'm not there, takes pictures of a lot of things and puts it in the patient chart and then sends me the chart so I can look at the picture and give her my thoughts on it. You know, methods such as that would be super important for those remote sites, I think.
So we have come to the end of our allotted time. For those of you who had questions in the question box we didn't get time to answer, I'll follow up with you via email, and you can always reach out to me if you have any other questions. I want to thank the panel and just ask if you have any closing thoughts as we close up for the afternoon.
No, thanks a lot for to the panel and Jimmy, and for the people who watched and had questions. It's really appreciated. And I think we all always welcome your questions as well. We get them from time to time, and we certainly probably like to get more. So thanks.
Yeah, and just to second Jimmy on, please come to the June 16th session, and there's going to be information about the law and the WAC changes that are going to be forthcoming. So there's a little bit of a lag time just in the rulemaking process. So the law is in effect July 1st, and then we're going to follow up shortly within the next few months after that with the new rules being effective as well. But the new law is effective July 1st.
And don't forget to continue to practice safe medicine with good practice ideas and collaboration with your physicians, and stay safe and wear your mask.
Thank you again for presenting this valuable information, and thanks everyone for such great participation. Just as a reminder, the presentation slides and recording will be available on our website within the next few days. I hope everyone has a wonderful week, and remember to take care of yourselves.